Hi, everyone, and welcome to Anesthesia Coffee Break. I'm Lahiro.
And I'm Stan.
And today, I think Stan's got a SAQ for me, the one that scored one of the hardest SAQs in the most recent paper. Stan.
So look, congrats to the trainees that set the exam last week on Tuesday. And I've gone through the paper. And certainly the consensus is that question 4 out of that paper was the hardest question there. I think that when we go through the components, it's really because of the specific requirements of this question that represent the difficulty. So I think that when Lahiro goes through, you might find that there are other components where you think that you've actually got the concepts well grasped. But there's certainly, I think, in the middle of the question where it asks for specific definitions where it can be quite difficult. And Laura and I are actually going to have a chat about that. We're going to have a chat about when you have these difficult questions, especially a very small, difficult component, how that plays on your mind, especially when you have one of the early questions in the piece. Okay, so the question was question 4. It was set into 3 parts, A, B, and C. 4A was briefly outline how body tissue composition is progressively altered by morbid obesity. And 4B was define each of the following terms: total body weight, ideal body weight, adjusted body weight, lean body mass. And C, briefly comment on the suitability of each of the above terms when used as a scalar for estimating an induction dose of propofol in a morbidly obese patient. So lots there to go through. And I think the other challenge here is that they haven't given you a distribution of marks. So you're not sort of sure where to spend most of your time on. I can guesstimate in terms of what each value is, but not for certain. So we're going to go through the questions. I guess on face value, what are your thoughts about this question?
Yeah, so first of all, again, the 3-part thing. So I'm going to, divide my answer up hopefully into, 3 pages even, and just try to write a good amount in each. And then potentially after I've written what I think is an adequate pass or the direct answer to the question, then I might try to add extra value points because it's hard to know exactly what the examiners might want. It'd be interesting to see. We can go back to this once the examiner's report actually comes out. But body composition, I feel like that's relatively easy because it's just, there's a bit of logic in that you probably all can know innately what the body composition is going to do. The definitions, now I've got to be honest, a few of those, I roughly know what these definitions mean, but I'm pretty sure I didn't memorize these definitions for my primary exam. And adjusted body weight, so adjusted body weight, not actual body weight, but adjusted body weight, wasn't something that I ever memorized. And I didn't actually know the term until researching for this answer yesterday. But, lean body mass.
And completely honest, and I think we are both honest here that we both didn't sort of click onto us what adjusted body weight was. So for all those out there, other trainees that didn't get it on the day, don't feel bad at all. We wouldn't have gotten it on the day either. And in actual fact, the term that I remembered was corrected body weight. So I actually had the terms confused, but they're the same thing. Corrected body weight and adjusted body weight are the same.
And then, so I think that may be the hardest part because you either know it or you don't, and you may need to add a formula. So that's B. And then C, commenting on the suitability of each of the above terms. That feels relatively logical as well. I feel like I could make a case for which dosing regime is good and which one's going to overdose and which one's going to underdose. And maybe after that, relate it to some other agents, but they're very much talking about induction dose propofol. It doesn't seem like a big answer. It seems like, there's just lots of passes answer, and there's a lot of, you either know it or you don't.
And I think that's a really good strategy that you've set out. When you've got these, I guess, long worded questions, it's good to break it up into components. And I really like the strategy that you've said in terms of that A goes on one page, B goes on another page, C goes on a third page. And then and then what you do next, you compartmentalize each of those questions and answer them on their value. Because I agree that the definitions would have been hard. You may have missed it, but they're probably like a small component overall of the mark. So really good strategy there. All right.
And to get started, so briefly outlining how body tissue composition is progressively altered by morbid obesity. First of all, I actually went to some resources suggested by Stan, which is Lachlan Rathy's, for the first year book actually has a massive section on this, using the terms exactly as they set out here. And I think potentially this is extracted from his new ANSCA companion book for the primary exam.
I suspected it came straight from there, lifted from there. Yes.
Yeah. I also went to deranged physiology, had some really good sections there, and also just Googled things, because there's so many ways you can calculate different body compartments. And I just wanted to check whether one source had translated to the next source in terms of definitions and how they would dose things. So that's the first thing about my kind of resources that I looked at. But yeah, I mean, I think the total body composition can be quite logical. So, there's an increase obviously in the total body weight. And then as that increases, generally your lean body mass or body weight will also increase compared to non-obese patients. And really what happens here is your total body weight increases linearly. Your lean body weight increases, but only up to a certain point. So at about BMI 40, your lean body weight then kind of levels off, where your fat weight keeps increasing, or your adipose weight keeps increasing. So just think of that. You have this large patient progressively adding more and more kilograms. The muscle mass also proportionally increases, or not proportionally, but your muscle mass also increases at a slightly lower rate than the total body weight. And then it plateaus at BMI 40, whereas your fat weight just keeps on increasing. So,
and there's a diagram for this, isn't there, that you want to show?
Yeah, might as well show this diagram here.
And what we'll do is, for those who are listening on the podcast and don't have that visual representation, we'll actually put this in the post.
Beautiful. So here it is. You can see linearly total body weight, lean body weight kind of plateauing off in fat weight. And that's straight from the British Journal of Anesthesia 2010. So that's that.
And that's important to know, because what you have here is that with the fat that's increasing, you actually need, muscle to actually carry that fat. That's why muscle increases. But obviously, at a certain point, increasing that muscle bulk doesn't increase in the same rate as you would increasing the fat. So that's not a good way to build muscle.
Not a good way to build muscle, no. Get on the protein. So I thought I might also add that, these changed body compartments really affect the pharmacokinetics of drugs, because now you've suddenly got a change in your, where your hydrophilic and your lipophilic agents will go, because you've got this, just change in body composition. I thought that would be something I'd add to this. And maybe with this whole, talking about the composition, I might then, so that was the direct answer of what the body composition looks like. But maybe the next step is to extend that. So theoretically, we would expect hydrophilic drugs, so water-loving drugs, to have a relatively preserved volume distribution. So think your muscle relaxants. You don't need to dose them on the extra fat weight. And your lipophilic drugs have an increased volume of distribution. And that makes sense. There's just so much extra adipose tissue that your lipophilic drugs, which is most of your, really a lot of your medications, your propofol and any other kind of lipophilic drugs, will have a preserved volume of distribution at a steady state. Obese patients, I guess interestingly, they'll have an increased cardiac output, changes in regional blood flow, the kinetics are all changed as well. And then this is all very relevant to anesthetic inductions and other dosing, but hepatic and renal clearance is going to be generally normal. And maybe at the end of all this, for most drugs, excluding muscle relaxants, so lean body weight, lean body mass, is the most appropriate dosing scalar for most anesthetic drugs. Again, excluding the muscle relaxants, which you generally dose on ideal body weight.
And so conceptually there, when we talk about lean body mass, or lean body weight, sorry, we're talking about the addition of the muscle component. Is that right?
Yeah, I think so.
Yeah.
And we'll go through that in the definitions of it, yes.
And I think that makes sense, because if you think about it conceptually, the muscle component has a higher amount of cardiac output, so it's actually quite active pharmacokinetically, and therefore contributes to the distribution of the drug. Yeah. Not as quick as the central compartment, but obviously it is a core component, and that's why fat is excluded in this. But then you're talking about, can we use that for muscle relaxants?
Yeah, actually, we might talk about that in the third section when we're discussing propofol induction dosing. But yeah, maybe we can move to the second point then.
The definitions. All right. So this is the black and white part of the question, where it's like either if you know it or you don't. And it sounds very much like you need to give a worded explanation and, if possible, a formula as well.
Yeah. So we'll discuss total body weight, ideal body weight, adjusted body weight, and then lean body weight or lean body mass. So total body weight is the easiest one. Is the total weight of the patient. You get that by measuring the patient. I think this is synonymous with actual body weight. Excuse me. But I wouldn't use actual body weight just because then adjusted body weight has the same letters. So just the total body weight.
But you're right. Actually, you see those other terms around, don't you? You see total body weight, actual body weight, and I think I've also seen real body weight as well. So there's so many different terms, but they all mean the same thing.
Yeah. And often adjusted body weight will have a small j, BW, just to account for this variability. Now, ideal body weight, this is kind of a strange definition to me because it's the ideal weight associated with maximum life expectancy for a given height. So, and the formula is interesting as well because it's height in centimeters minus 100 in males or 105 in females. And so this is what, the weight the person should be, because they're assuming that every single person of a certain height should be a specific weight. But we know that that's not true. It's a really bizarre assumption. We know that there's, genetics involved and various body types involved. And, I just haven't seen these studies of what is the absolute best weight for a height. But, this is, I guess, conceptual, helps us to, helps us to think about things in a certain way. And so the ideal body weight is simply based on height. Now, there are
there are other formulas. Yeah. So tell us about the other formulas that you know.
Actually, so look, there's a whole bunch of other formulas. I didn't look them up just because they could be reasonably complicated. Actually, some of them when they're like one value times 22 to the power of something.
In fact, that's the one I think that's been represented on the primary LO WordPress. So I think it's important for us to actually talk about that, because that's the one that the ex-examiner has actually posted that they like. So that's So that's the one you said, which was 22 multiplied by the height in meters squared. So you'll see you see different variations. You'll see one where it says 0.0022 times the height, but that's in centimeters. But if you use meters, it's 22 times the height, meter squared. So that's the other one that you guys need to know. And then the one that I previously knew was the one from Miller's. But I think that's, looking at this one here, this one's much easier to remember. So I would use that one there. Or in fact, the one that you said, La, which was height minus 100, wasn't it?
Yeah, that's right. So I might just go through that again quickly. So one definition is height minus 100 in males, or height in centimeters minus 105 in females.
Yeah.
Or the one by the examiner is 22 times height in meters squared for males. Yes. And then ideal body weight for females is 22 times the height take away 10 centimeters squared.
Yeah. Okay. That makes sense.
Again, based on height.
Yeah. And then there's one in Miller's, which I think, as I said, the one that I remember, but you know what? It's a little bit more tricky. It's that it's 50 kilos plus a kilo over 152 centimeters. Or if you're female, 45 kilos plus a kilo over 152. So again, just many different variations out there.
Just plugging those numbers in, so there will be a slight difference. So, it's nice to kind of see what the trend is between two formulas. So 107 centimeter male will be 70 kilos ideal body weight, but then using the 22 times height in meters squared is about 63 kilos. And
right. Okay. It's a bit of a difference, isn't there?
Yeah, a bit of a difference.
Okay.
Yeah, good. So that's the ideal body weight. Adjusted body weight, then, this again, it's hard to really conceptualize what this definition is, but it was a scalar derived from aminoglycoside pharmacokinetics in obesity. So I suspect that it was done using studies of what's going to be appropriate for this certain medication. And they say it's the weight that represents the metabolically active lean body tissue. So metabolically active lean body tissue, and therefore prevents over or underestimation of nutritional requirements in the obese subject. Again, that's a whole bunch of definition there. And it's hard for me to really conceptualize that except the fact that I think of it as, total body weight is the largest, adjusted body weight is the next largest number. Then we've got lean body mass and then ideal body weight. So I think I don't get too much more involved in that with adjusted body weight. In terms of the formula, adjusted body weight is your ideal body weight plus 0.4 multiplied by the total body weight, take away the ideal body weight. So ideal body weight plus 0.4 multiplied by the total body weight, take away the ideal body weight. Maybe we can give some figures there. So a 200 kilo person at 170 centimeters, if we were to take away from that weight, so from a height, there 100 in a male would be 70 kilos ideal. So it'd be 70 kilos plus 0.4 times 200, take away 70. Might as well give that a quick calculation then, 0.4.
I know. Imagine doing this in the exam. That's almost impossible.
Yeah, you just can't. You can imagine you wouldn't be required to do that.
Yeah. And look, just as an aside, I think we're going back to sort of year 10 physics. Someone might pick you up on this. What's the difference between mass and weight? Because, we talk about lean body mass, lean body weight.
Yeah, I mean,
is that going back too far for your high school physics?
Yeah, they're used so interchangeably, and with gravity at this constant, it doesn't matter. but you're right.
No, so weight is the force. From what I remember, weight is the force, and mass is the matter. So the mass doesn't change, but you're right. The weight is due to the gravitational force.
Yeah.
But for all intents and purposes, they're the same. Now, with the adjusted body weight, so I really like the way that you put it into like a ladder. So total body weight, and then after that, adjusted body weight is next, which is more than your lean body weight. Mm-hmm. And so that suggests that with the adjusted body weight, there's more than just muscle involved with it that adds on the extra component. And what you would say is that with the adjusted body weight, there would be, if you used it, there would be theoretically a larger volume of distribution than the lean body mass. So interesting. Yeah,
very interesting. So then lean body weight is the difference between your total body weight and your fat mass. So just think of a patient, very large, take away all the fat mass, and now what you're left with is, your lean body mass, which is all the non-fat tissues. And again, you've got some interesting formulas. So for a male, it's 1.1 times the weight, take away 128, multiplied by the weight over the height squared.
Yeah.
And then in a female, it's 1.07 times the weight minus 148, and in brackets, the weight weight divided by the height, all squared. It's easy enough to plug this into a calculator. And I think there's other things like 20% above the ideal body weight is another way of getting to that number.
Okay. But I think, this is the one that's known. This is James's formula, which is used in the Schneider model for propofol.
Yeah.
So I think, you know what? I never thought you would have to memorize this. Like I went through this last year and I said, I looked at the formula. I went, I thought it was a very low probability that you'd have to memorize it, but there you go.
Yeah.
So like just on the ladder again, just to summarize, can you go through from, now that we know all from the heaviest to the lightest?
Mm-hmm. Yeah. So heaviest to the lightest.
Yep.
So as we mentioned, total body weight, then adjusted, then lean, then ideal.
Okay. So total body weight, adjusted or corrected, lean body mass, and then finally your ideal body weight. All right.
And
fantastic.
Maybe there's a time. So Stan and I actually were involved in a really, really tricky case back in the day. And the patient, every time I have asked people to guess the weight of this patient, they always underguess by 100 kilos or so. But this patient was a 280 kilo patient. with a height of 1.78 meters and a BMI of 88. So exceptional. I don't think it'll be very difficult for that kind of case to ever come up again in my life. I think that's just one of those very rare situations. And again, we're not going to talk about any specific details because that's not what we're here for. But essentially, when I plug these numbers in, so we're giving this patient a general anesthetic and we're thinking about the dosing of propofol and muscle relaxants and just going, we are a bit lost. We really went on gut instinct for a lot of this. But if I plug in the numbers, the total body weight is 280 kilos. The adjusted body weight is the adjusted body weight is 155 kilos.
Okay.
And then the lean body weight is different depending on the equation. So if we use the James equation, it's negative 73 kilos. So that didn't work.
Yes, because remember that, yes, with the James's formula, it's a quadratic function. So after you hit above, for females, I think 40 odd BMI, it starts becoming negative. Yep. So yes, that's the big limitation with the James's formula. So you might need to use that other formula that you talked about.
Well, so then I just went to this calculator and I plugged in the numbers, and they've got two other options. So the BOA formula gives 108 kilos of lean body weight, and Hume formula 116 kilos roughly of lean body weight. Finally, the ideal body weight was 73 kilos because the patient was 178 centimeters. So Here we have 280, 155, let's say 110, and then 73. We happened to dose this patient. We had a syringe of propofol and we were running a TCI infusion. And, you gave 200 milligrams of propofol. And that's roughly right if we're dosing on lean body weight. 110, 200, sure. That whole one vial is good for everything kind of worked in that situation. And when I ran the TCI pump with the Marsh model, the maximum kilos was 150, which is actually about the adjusted body weight. So that happened to work out pretty well for us. But again, we were titrating to all the other variables that we would normally use, including, the fact that the patient, the heart rate, the blood pressure dropping, as well as having a BIS on there for what it's worth. Knowing the trickiness of a 280 kilo patient, I feel like we did pretty well to, get these numbers correct.
And that's really quite an interesting point and segue to part C, which is comment on the suitability of each of the above terms when used as a scaler for estimating an induction dose of propofol in a morbidly obese patient. And I think, with the example that you gave of this patient of 280 kilos, let's work out what the doses of propofol would be for each of those scalar weights.
Yeah, let's do this. So first of all, I'll go through roughly what it would, whether it underdose, overdose, or be appropriate. So total body weight, imagine 280 kilos of times 2 milligrams per kilogram of propofol. That would, horrendously, being over 500 milligrams of propofol, it would be far more than this patient needs. So total body weight, because it's including all of that fat mass, is just too much for propofol, which doesn't rapidly distribute on induction, for this patient. So that would be too much. The next one, adjusted body weight, would probably give you a small overdose, thinking 155 versus a lean body mass 110. So it'd probably give a small overdose, but in a young patient, that's not going to affect it too much. Like if I gave this patient 300 versus 200, it'd probably be a good enough dose, really. It wouldn't be terrible for this patient. Lean body weight is most appropriate, like we said, for most anesthetic drugs. And when you look at the charts, often a lot of your, opioids are also on, dosed on lean body weight. Now, ideal body weight, imagine 73 kilo ideal body weight for induction, times 2, 140 milligrams seems so underdosed for an induction. Now, just to extend that, propofol maintenance maybe should be on adjusted body weight. So while it's a small overdose in induction, it's probably the better number for propofol maintenance. Yeah, so I mean, that's probably as much as the question asked for. But I think just for the podcast, really, just to kind of throw things out there, I know that rocuronium, cisatracurium, these muscle relaxants, ideal body weight's probably the right number. And So imagine a 73 kilo person giving a intubating dose, roughly 70 to 90 milligrams, would be pretty reasonable. Suxamethonium, interestingly, which is the drug we gave for the induction. So I remember reading in one of the pharmacokinetic, anesthetic articles that no matter what the weight, you'd go to 150 of Sux.
Yes.
But they are saying that total body weight, based on clinical trials of the best intubating conditions, was the right method of dosing suxamethonium. So not necessarily theoretical, but just from clinical trials, total body weight may be correct. That's what the examiner says in his books. And I know, so we gave 2 vials of Sux, 200 milligrams, and the intubating conditions were fine. There was minimal fasciculations that we saw, but time had passed, put the laryngoscope in to amazingly see a very nice grade 1 view, which, there you go, 280 kilos with good other factors and good positioning meant a very easy airway. Now, ventilation was a whole other story, but yeah, we can talk about it in another section.
Yeah, really interesting. And I think, what was challenging about the case as well was there were no pharmacokinetic models that you could use for this patient. So in other words, that, we used a manual induction bolus. And after that, we discussed this actually in terms of what we needed to do with regards to if you wanted to run TCI. And I think you chose the MARSH model with a plasma targeted concentration, which, if you look at it, meant that you certainly don't get that over bolus that you do with effect site concentration. Yeah. So I think this question also came about, and maybe sort of almost a gentle introduction to what's going to be coming out in the next couple of weeks or months, if it hasn't already. The new Elevate model with the propofol syringes. So that's coming to our department, and I've seen it in other departments and maybe present in other departments already. But you will see the model being updated into your propofol syringes, and I think the Elevate model does discuss the idea of adjusted or corrected body weight, which possibly led to this question coming up to this exam here.
Okay,
but I think in terms of discussing the Elevate model, it might be a bit too early for that. But I think what they've done is they've just discussed the idea of weight and the scalar quantities associated with it.
Hey,
look.
I mean, as I go through this, Dan, it is hard because you either know it or you don't. But, if you're not expected to do the formulas, if you can talk about each of the definitions conceptually, if you can logically think about how body weight composition changes with increased weight, maybe chuck in the graph, because it's a pretty easy graph to remember, aside from much more complicated graphs that you do have to remember, like Wigger's diagram. And then, you learn these induction. It's not much to learn. It's just, if you haven't done it, it would be quite intimidating. And I suspect that maybe, even though most of your trainees said that this was the hardest question, potentially they wouldn't have scored too badly on it. So it'd be interesting to see the marks at the end.
Yeah. And I think you're right. Hopefully, if you took out the B section, I think A and C certainly, you could answer. With A, definitely you can answer. C, B and C are probably tied together because you have to understand actual body weight and ideal body weight. I think for most trainees, total body weight and lean body weight would be something that they would understand and easily explain. I think what's difficult to explain conceptually are the ideas of adjusted or corrected body weight and ideal body weight, because if you go back to your definitions, they weren't very straightforward, were they?
Not at all.
Yeah.
Hey, Stan, so that's pretty much the answer to the question. I mean, should we talk about some of the interesting stuff in that case that people don't really, like when people talk about, like, from a practical part 2 point of view, what morbid obesity issues are. I feel like there's a lot of things that are talked about, but in our experience, when we did this case, there's some other unique things that, were probably worthwhile mentioning. Should we mention those in a few minutes?
Yeah, absolutely. Yep.
But it was good having you there, because I think the first thing is you just need 2 people to be able to run this thing, because there's so many things that just take more time. I mean, trying to get the IV in, like the depth of there's no superficial veins. There's tiny superficial veins. The proper deep veins that we're trying to access are like 2 to 3 centimeters down, and your lines, your IV cannulas just aren't long enough And even when you finally got one in, but then it was because of the traction with all the tissue and tissue movement, it kinked. So it needed to be stretched. So think about a ultrasound guided difficult vascular access with maybe a centimeter in the vein. Now you're tractioning it, pulling it back to make it work. That was a tenuous piece of IV access. And so we decided, look, we're just going to do a central line awake for the induction because this is not going to be, easy. And then
it reminded me of those, those chubby little neonates or infants that you see, and but just on a larger scale, like how they've got those rolls of tissue,
yes,
and then the depth to their veins are actually they're not superficial; they're actually quite deep in. And so, think about it in terms of the relative nature of that, but on a much larger scale.
Yeah. And then we had we had the whole list for this one case, which, normally take a short, an hour and a half would be a reasonable time for this case in normal, with a normal BMI patient. But in this case, we started at 8:15 and it took till 12. So that's the extra time for all the little bits of things. And then doing the central line, like literally needed a person to hold the chest, mass down and then tilt the neck and hold that. So there's this gap of a window where you had to get through to put the central line in, which was just taking away mass, which was incredibly difficult. The traction for my assistants helping was incredibly difficult, I think.
And what was really interesting? After the traction, the depth to your internal jugular wasn't actually very far. I was so surprised because I remember, like with the ultrasound, I was like, mate, this is going to be really deep in. And I remember turning up the depth to about 5 centimeter depth. Yeah. And then we looked at it and went, oh, it's only like 1 to 1.5 centimeters from the skin. So turn it back down to, what you normally would in terms of the depth. So that was quite interesting.
Yeah, the neck tissue around the actual neck was preserved. Like it wasn't that much extra. It's just the overlying extra stuff from the neck, from the cheek and the upper head and the chest. That was really what was doing that. And then, it was, I guess, just for the surgery, having to position the mass, various parts of the abdomen away using strapping. So nothing was accessible on the head because we had bars everywhere with tape strapping to get surgical exposure. Which was...
and just before that, we did that, your airway management. What do you think about the airway?
Yeah, I mean, I've never thought of, I've thought of some obese patients as looking very difficult. They've had small mouth opening and obesity, but really this patient, ramped up reasonably well, but not optimally. It was just too hard to get an optimal ramp in this large patient. But I didn't use the Oxford pillow. I just used the bed and tilted it up and tilted the legs up so I wouldn't lose too much, cardiac preload because of pooling in the legs. And the patient had great mouth opening, so it was easy to get maybe not easy to get a grade 1 view, but it was a grade 1 view. I had a CMAC ready, but I didn't use it.
And I think that's the normal consensus, isn't it, for obese patients, is that they don't actually represent, with the appropriate positioning, a difficult intubation.
Yeah.
But did you? I think you back mask ventilator as well, didn't you? Or
I do. Yeah, right. So I do this thing with every patient I'm doing if they've I guess any patient I'll induce, especially the ones that I know are difficult. So we gave as soon as the patient went to sleep, I just wanted to know, can I bag mask this 280 kilo patient? And I've been surprised. I've had, in the high 100 patients, as soon as I've given the propofol and the sucks, I can bag mask them. And I'm amazed that I'm able to do that. And this patient was the same. As soon as the propofol went in, just put a Goodell in, got my good grip on there, and I was able to bag mask really effectively. And when the relaxant started kicking in, it was even easier. So that gave me kind of that sense of, at least I can bag mask this patient. And it was just this really nice sigh of relief before I went in with the laryngoscope. So yeah, that's if I couldn't bag mask because of lack of paralysis or just the difficulty of the mass everywhere, it would be no different than me waiting for the sucks to work. So I thought there's nothing lost with me gently putting a Goodell in, trying to bag mask this patient.
All right. I think it's time to maybe open it up to the audience. Hey,
how about the ventilator settings? That was interesting.
Oh, the ventilator settings. Yeah, tell us about that.
So kept alarming. It was easy.
This is a respiratory question here. Yeah.
Yeah, that's right. So I think Stan, you're saying, oh, look, we're just going to have to increase the max pressure because it's
Yes, because I think the initial setting you put was, which I think most of us do, pressure control, volume guaranteed.
Yes, that's right.
And then the maximum pressures that that system is allowed to deliver on default is 40 centimeters of water. And I saw the other components that you put in. I think you put PEEP of 15. Is that right?
Look, I varied with PEEP based on compliance, but yeah, I ended up at 10. Absolutely.
10. Okay. Yeah. So I think when you do that, what that means with the ventilator setting, so let's say it's a 10, that it can only generate an extra 30 centimeters of water before it reaches its max limit to try to deliver the set volume. And think about that. You've got this, 280 kilo mass. Well, not quite, but it's all sort of, at the front that you have to ventilate again. So that was actually quite a lot in terms of weight that actually would affect your chest wall compliance.
Yeah. So there's a few things. We increased the pressure to what we thought was reasonable based on the risk. So I went to 45 initially, and then saying you're like, yeah, just go to 50. And I was like, yeah, that's very reasonable. So I went to 50. Pressure control ventilation volume guaranteed gives you, I guess, just like anything, the maximum volume at a certain pressure, and pressure was the limiting variable here.
Correct.
So absolutely. Normally I just do volume control ventilation. And then because your IU ratios are 1 to 2, if there's an obstructive picture, I would definitely not do this. But because there wasn't obstructive, this was more of a restrictive chest wall defect. I wanted a slow upstroke. So I changed the IU ratio 1 to 1, just so the inspiratory rise would be slow and then my pressures would be lower. And then, just kind of 500, 600 tidal volumes and fast respiratory. And even with that, so most of the case, the end-tidal CO2 is 50, but we're just keeping it there. And that's probably the main takeaways, really. And, bearing my PEEP so I could still have volume, but try to minimize atelectasis and maximize compliance is a massively tricky situation.
No, I thought it was very well done. And then, in fact, let's comment about the extubation, because extubation is always a little bit tricky with these patients, isn't it?
Yeah, that's right. So, every patient, when they're slowly recovering their muscle function, will flail about a bit. But when you have a large patient, I just asked the tech to get many hands. I needed, you don't want a slightly awake patient flailing around, pulling their tube out when they're not absolutely ready. So I had, someone on each limb just to make sure that something didn't happen. The patient was not too bad as they woke up. Had them sitting bolt upright. I had a Goodell in as my bite block just to have an extra adjunct in case I need to ventilate. I had all my safety stuff ready, suctioning, bite block, all my airway equipment ready to go. Didn't have my drugs drawn up, but I knew it was there and ready to give again, and an extra pair of hands. And then, pre-oxygenate it absolutely again. And then I gave 500 of Sugamidex, and it wasn't enough to reverse. So to get the trainer for greater than 90%, had to give it a total of 700 of Sugamidex. And have the propofol down to about, I think, 1.5 micrograms per mil in the plasma or the effect site, maybe.
Now, that's a really interesting point you made. So the rock that you gave wasn't based on total body weight.
We were dosing it 50 at a time. I think we gave a total of 150.
150. Okay.
Yeah.
But yet the Sugamidex is based on your total body weight. Almost, isn't it? If you think about this, because you didn't give 50 right at the end, you sort of gave 50 probably in the middle of the case. But to reverse her, you had to give 2 milligrams per kilo.
Yes. The trainer 4 was already past having 2 counts. Yeah. So I knew I could give 2 milligrams per kilo. So I gave the 500 milligrams.
Oh, you gave more than 2 milligrams per kilo. Yeah.
So just under 280 times 2. So I gave
560. Yeah.
Yeah, but there's like 30% trainer for return.
Yes.
But then it could also be the fact my neuromuscular monitor isn't accurate enough at that depth to the nerve. So who knows? But, I can't risk anything here with this patient. So I just gave an extra 200 and it was fine.
Interesting.
Yeah.
Oh, good work. Well done.
Yeah.
Great case. Great case. I mean, those are the challenges I think that we face now, in the...
That's right.
In this coming decade, hopefully that changes. But we're certainly seeing more of those cases, and that was, I think, one for the memory bank.
Yeah, that's right. That's probably good. So we'll close off now before we ask questions, I think.
Yeah. Let's do that.
Hey, thanks for everyone for listening. So this has been Anesthesia Coffee Break, and please share with anyone who might be interested. And we'll see you again for the next episode. See you guys. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.